Respiratory Syncytial Virus (RSV) is responsible for infections of the upper respiratory tract. It occurs at any age but is predominantly found in infants and young children. Although there is no complete maternal protection, the newborn is relatively protected in the first weeks through maternal transplacental antibodies. The infection shows a seasonal distribution similar to influenza. Statistically, more than half of infants develop an RSV infection in the first year of life, and almost all by the second year. By age 2, almost the entire population has contact with the virus, but the lack of long-lasting immunity leads to reinfections later in life. Individuals infected with RSV can be contagious from the first day after contamination, even before the onset of symptoms. Adults are less affected, occurring predominantly in high-risk patients, especially those who are immunosuppressed. Humans are the only clinically relevant reservoir. Infection is transmitted through aerosols. The entry portal is the mucosa of the upper respiratory tract, particularly the ciliated epithelial cells and the conjunctiva. The clinical picture is initially dominated by nonspecific symptoms of an acute viral infection. RSV's clinical spectrum ranges from mild forms to severe respiratory failure requiring mechanical ventilation. Primary infections are usually the most severe and may lead to bronchiolitis and pneumonia. Bronchiolitis manifests differently in children due to the much smaller caliber of their airways. Local edema may produce airway obstruction almost instantly, leading to dyspnea and tachypnea. Reflux and repeated vomiting worsen dehydration and further contribute to the deterioration of the general state. Bronchiolitis may also manifest with pulmonary atelectasis and recurrent apnea. Atelectasis typically occurs in the right upper lobe. Premature infants have an increased risk of apnea. Secondary bacterial infections are extremely rare. Most co-infections involve other respiratory viruses. Clinically, RSV infection is difficult to recognize. The first solid clues often appear during hospitalization. Diagnosis is based on viral PCR from nasopharyngeal samples. Rapid antigen tests have high specificity but lower sensitivity, so a negative result does not exclude infection. There is no specific treatment. Management consists of general supportive measures and adequate hydration. This hydration is essential to facilitate the mobilization of pulmonary secretions. Parents may perform a pseudo-chest drainage technique through very gentle percussions using only finger movements. Hospitalized patients usually require oxygen and assisted or controlled ventilation. Nebulization with bronchodilators or adrenaline may reduce airway edema. The administration of nebulized adrenaline should not be delayed when it is clinically indicated.